Hello, and welcome to the CME CE accredited video discussion titled Overcoming the Challenges, Strategies for Managing Patients with Multiple Sclerosis. I'm Dr. Edward Fox, the Clinical Assistant Professor at the University of Texas Medical Branch and moderator for this educational activity. I'm pleased to be joined today by two individuals who are here on my left. On the near left is Dr. Clyde Markowitz, who's the Director of the MS Center at the Hospital for the University of Pennsylvania. And the far left is Dr. Barry Singer, who's the Director of the MS Center for Innovations in Care at the Missouri Baptist Medical Center. So welcome to you both. Thank you for joining me.
Thanks, Ed.
Thanks.
All right. So we'd like to begin this presentation with a segment 1, which is entitled Managing the Disease, Diagnosis, and Treatment. We're going to be discussing several topics here. One of them is going to be the pathophysiology and the immunologic state of this disease. MS is a diverse disease, and there's a number of subjects to discuss in terms of the pathology, but also the underlying immunologic malfunctions that occur in MS. After talking about that, we're going to be talking about the difficulties that we have in making this diagnosis. It certainly is a complex topic as well, and what we hope to do is shed some light on the issues that we deal with every day in making the proper diagnosis. We will then go over the topics of current and also the upcoming and emerging therapies for MS, several that are not yet available will be potentially in the future. And then lastly, we will go over a specific case that will have some details that I think will get into the topics that we've covered above. So upon completion of this first segment of the CME program, the hope is that we understand the pathophysiology of multiple sclerosis a little bit better, and also talk about the treatment strategies that we have and also the outcomes that we're looking for in terms of the treatment of multiple sclerosis. By discussing the overall patient quality of life, both in the treatment of individual symptoms and also the disease as a whole, we do hope to discuss the overall concepts of treatment of care. And the assessing of the tools that we use, the measures to make the accurate diagnosis, we'll get into the topics of what we have in our own armamentarium to be able to follow patients to determine whether the treatment has been effective or not. And by going into individual clinical trials, looking at the investigational agents that are treating multiple sclerosis currently and in the future, we hope to shed new light on what's going to be happening in the future. As a pre-assessment question number 1, we have the following. Teriflunomide, 14 milligrams versus 7 milligram dose in the TEMSO and the TOWER trials have shown each except the following. So which one of these is not true? Number 1, did it show lowered annualized relapse rate versus placebo? Number 2, improved MRI activity. Number 3, stronger efficacy signal observed with the 14 milligram dose. Number 4, significant differences in safety and tolerability profile between the two doses. And lastly, significantly delayed disability progression. So please choose the following that does not apply, the false statement. And for question number 2, we have the following. Which of these is true regarding the DEFINE trial? Number 1, alemtuzumab significantly reduced the ARR by 44% at 2 years compared with placebo. Number 2, BG12 significantly reduced the proportion of patients who relapsed by 49% at 2 years compared with placebo. Number 3, the primary endpoint of reducing annualized relapse rate was not statistically achieved. And number 4, teriflunomide reduced the number of GD-enhancing lesions per T1 scan. Please choose your selection now. Well, I now wish to go to our first segment here in section number 1. And for this, we're going to be talking about the pathophysiology of the disease, the immunologic dysfunctions. And for that, I turn it over to Dr. Markowitz. Clyde?
Thanks, Ed. So we're going to talk about the pathogenesis of MS. And, one of the problems that we have is that we really don't understand what causes MS. There are a number of things that we've observed, which include that patients can sometimes have a family history of MS, which supports an idea that there could be a genetic component. And there have been some twin studies that have supported this, where one twin and the other twin may or may not have MS, but the concordance rate may be as high as about 30%, as opposed to what you see in the general population, which may only be about 2%. In addition, there have been some studies that have looked at specific genes, and there seems to be some genes that may be participating, particularly in the immune response genes, that may be at a higher risk if they carry certain alleles of those genes. In addition, there may be environmental factors that play into this, and we don't know what they are, but there could be viruses, there could be toxins that might end up being involved as what we call molecular mimicry, where the immune system sees a particular portion of a virus or bacteria, and it looks a lot like native proteins in the brain, or myelin, causes an inflammatory response against that virus, but then also subsequently will attack the brain and spinal cord, thinking that that's foreign material. So we don't know exactly how much of each of these components play, but we know that it's important, and we know that the immune system plays a very important part in this whole process, because when we look at the pathology of MS, we see a lot of immune cells. The first hints of this were from pathology specimens, where we actually looked at the brain and the regions around blood vessels, and we found that there's a tremendous amount of immune cells in and around blood vessels, thinking that the immune system's coming out of the blood vessels, going into the brain, and causing the inflammation. We also see that around those blood vessels you see demyelinating plaques, areas where the myelin has been stripped away from the nerves and there's damage. And that's what the hallmark of what we see pathologically for MS is. And in the recent 20 some odd years, we've actually had now new techniques with MRI scans where we can look at the brain and see, the lesions specifically in various regions of the brain. But in addition, if we give an injection of gadolinium, you can see areas of active blood-brain breakdown. So there's fairly good correlation between what the brain MRIs show with active GAD enhancement and what you see pathologically. So one of the things that we have to figure out is, well, what's driving these immune cells into the brain? What we've learned is that there are a number of immune cells that function to keep both the body in check and clear out viruses and keep your body from developing tumors, but we also know that there are situations where the immune system can get out of regulation, and that can lead to an autoimmune condition. And we don't know for sure, but we think that there could be an autoimmune condition happening in MS because there seems to be a dysregulation of certain immune responses. We know that immune cells can either be in a T0 phenotype, where they are naive, they haven't been activated, and when they get activated by some sort of a stimulus or an antigen, they can then develop into an active pro-inflammatory type, which we call Th1, or they can actually move into a more Th2, which we'll call a slightly anti-inflammatory type. And depending upon what the ratio of Th1 to Th2 is, may actually be responsible for this process of autoimmunity, where if there's too much inflammation and not enough, so to speak, anti-inflammatory, you could have immune responses that are just not correct, just out of control. And there's a whole nother regulatory loop that happens in MS and in general, which is the immune response will also generate a regulatory loop that will shut down inflammation after the job's been done. So this all happens, and we don't really know exactly which piece is being, out of control in MS, but what we think is happening is that the regulatory loops may not be adequately controlling the pro-inflammatory loops. So there's a notion called Th17, which is a pro-inflammatory process, and there's been some studies to suggest that in MS that may be out of control and maybe not adequately monitored or regulated. So one of the strategies that we've come up with in terms of therapies, which are important, is that maybe if we can control or deviate the immune responses a particular way, we might be able to control the disease to some degree. So this is just going to describe for us a little bit about the balance issue, right? So we know that there's a whole bunch of cytokines that the immune cells will release, and when they release those cytokines, they can cause a variety of actions and functions on the surrounding environment. So if you have too much pro-inflammatory cytokines being made and not enough of the anti-inflammatory cytokines, you might have the MS condition. If you can go ahead and try and balance it, and that's what some of these therapies do, you would be able to regulate the disease and keep it quiet. The diagnosis of MS has been a challenging issue for us over the last 50 some odd years. But what we've come up with, and I think it makes sense, it used to be that we'd start out with a requirement for people to have 2 attacks separated in space and in time. What that meant was that you needed to have 2 areas of the central nervous system separated by at least 30 days. And that was fine, but in the advent of imaging, where MRIs have come about, we've learned that the disease is actually way more active than just purely on clinical grounds. So that now we can make a diagnosis even after 1 attack if we can demonstrate that there's activity on an MRI scan, and you can actually use the MRI scan to show dissemination in space by finding 2 areas in the central nervous system by imaging. You don't have to actually have that on clinical grounds. And so that's actually been a real helpful tool to us to be able to use the MRI scan to come up with a diagnosis earlier. And the advantage to it is, when we've started to do our clinical trials, we've found that if we wait and delay treatment, people don't catch up and they can acquire disability. And if we get treated earlier, people do better. So the notion for doing the MRIs the way we do it currently is to try and make a diagnosis as early as possible and be able to initiate therapy. So how early can you go is really what it comes down to. So if somebody's had 1 event and you get an MRI scan and you see several lesions in the brain and several lesions in the spinal cord, you have dissemination in space, but you don't have dissemination in time. Well, it's always been a challenge where you could say, well, let's just wait and try and do another MRI at another time point. And during different periods of time, we said, 3-month time points. Well, now, in 2010, a criteria called the Magnum's MRI criteria allowed us to use the MRI scan on a single time point. So if somebody has a clinical event and you do an MRI scan and there's GAD-enhancing lesions and non-GAD-enhancing lesions on that one scan, and those lesions are not involved with the clinical symptomatology that patient is having, you can make a diagnosis as dissemination in time based on that one MRI scan. So this brings a number of questions to address. So for one, having the new McDonald criteria, I think it really affects how we practice neurology these days. And I think, whether we should or shouldn't be doing spinal taps anymore is an important piece. And then what do you do with these radiologic isolated syndrome cases? So let's open it up to the group here, and maybe we can just, hash out some of these issues. So Ed, how do you think we manage some of these issues?
I think having the updated criteria has been very important for us because we've seen in trial after trial those patients who have delayed onset of treatment do not fare as well as the people who get early onset treatment. So if there's a way to look at an MRI and be able to establish that dissemination in space and time, I think we have an advantage that we can use to be able to get a patient on medication at the appropriate time and not wait not only for a new clinical event, which may or may not be ever resolved, but also looking at the onset and development of brain atrophy and black hole formation and other things that certainly could be prevented potentially with earlier treatment. I'd like to open it back up to Barry to see if you have any different thoughts on that matter and how you use the lumbar puncture in clinical practice and effort to make the diagnosis.
So Ed, I think with the 2010 McDonald criteria, I think it's very useful going forward for clinical trials. So we a lot of times have to wait, as you said, for new MRI activity to have to make McDonald criteria for the diagnosis of MS. In clinical practice, though, we know that many of our agents have been shown to be effective for clinically isolated syndrome. So you can start treatment early on in the disease course and not wait for new MRI activity anyway. So I think it's going to be more useful for clinical trials going forward. But it helps clarify, those patients with enhancing lesions at baseline and old T2 lesions, we can initiate treatment a lot sooner and be very confident those patients are high risk for MS. In addition, so lumbar puncture, still doing lumbar punctures for many of my patients. I think it's very useful, especially when the diagnosis is not clear. If I have a 25-year-old with optic neuritis and a classic-looking MRI scan, I may opt not to do the lumbar puncture. but you have a patient with a number of neurologic symptoms, not much finding on exam in their late 40s, and they have hypertension, diabetes, and smoking, and they may have small vessel disease, it's very difficult sometimes to nail that down without looking in the lumbar puncture. So I think it's very important to help confirm the diagnosis, and there's some diagnostic or even prognostic information that you can get from that cerebral spinal fluid.
I agree with that. And so taking it to the extreme of the difficulty we have with the diagnosis, Clyde, I will ask you what you do with the radiographic isolated syndrome patients, because they're not that infrequent. I mean, we certainly are going to run into those, especially with the increased utilization of MRI and investigating whether it be potential trauma or patients with headaches, as you mentioned. So how do you follow those patients?
So, I mean, it's a difficult thing because at this point we don't know what to do with that information, right? There's no guidance for us that says if you see a scan and it looks like typical MS lesions that you should consider therapy or not, right? There's no data to support that. But there is some suggestion that, look, when we do our CIS trials and we do an MRI scan at the time of their first event, you look and you see a number of lesions in some of those people. You know that those lesions had to have occurred in the past before their first event because they're all asymptomatic. So are we just looking at an earlier time point? And really it is MS at that point, but we can't make a diagnosis because the requirements are a clinical event. So it's a tough thing, and we don't know what to do with it. But what I'm currently doing is if somebody comes in and their scan looks classic for MS, I let them know that I can't make a diagnosis at this point. I might do a spinal tap for that individual patient because there is data to suggest that if they have abnormal spinal fluid in a distribution consistent with MS, that their risk is greater to go on to develop MS than if it was negative. So I might offer that. And then I scan them periodically. And at this point, it might look like another scan in 3 months or 6 months, and then just monitor and watch them closely and have the patient start to, monitor themselves for symptomatology, things that maybe they didn't think about in the past, that maybe, they just thought was, their arm was numb in the morning and they slept on it funny and it lasted a couple of days, to really start monitoring those kind of things. Because if that's the kind of thing that they didn't think about, but now retrospectively they can say, okay, I'm going to start watching this a little closer, we may pick up their symptoms sooner than waiting. So, but I don't treat anybody at this point. But what's happened, interestingly enough, is that there are some people who show new lesions on their MRI scans over time. And in those cases, I have a conversation with the patient about whether we think it's appropriate to do anything about that and start therapy with the idea that it looks like it's probably going to evolve into MS. So I've actually had 1 or 2 patients who've elected to go on therapy in that setting, even though it's not indicated and I don't have a confirmed diagnosis.
I think the most important takeaway from this is the need to monitor those patients, that we can't just say, well, you don't have any symptoms that sound like MS, so you will not get MS. We need to monitor those patients long term.
So we're going to move on now and talk about MS therapies. There's been amazing development over the past 2 decades on new treatments for MS. Before 1993, we had no treatment. And currently we have multiple agents FDA approved and some in late stage development and hopefully soon FDA approved. So in terms of our FDA approved therapies, we have the interferons, which include subcutaneous and intramuscular administrations. And these medications have been very effective for many of our patients, and now we have long-term safety data for these individual agents. In addition, we have glatiramer acetate, a subcutaneous injection, that has also been proven effective in reducing new relapses in MRI activity. Mitoxantrone is another intravenous therapy that has been established for the treatment of primarily aggressive relapsing remitting disease. In addition, we have natalizumab, which is a monoclonal antibody, our first monoclonal antibody therapy, which has had robust effects on reduction of relapse rate. And recently, we've been able to figure out which patients can be more safely administered natalizumab. In addition, we have our first oral treatment for MS, which is fingolimod, which was approved in October of 2010, which has also been shown very effective in reducing new relapses, new MRI activity, and reducing the likelihood of progression of disability. In addition, we have some new therapies that hopefully will be available to us in the near future to treat patients with relapsing forms of MS. One of those agents is teriflunomide, an oral agent, And BG12, another oral agent, oral laquinimod, which may potentially come forward, and alemtuzumab, which is a monoclonal antibody given annually. So let's dive into these individual therapies. So let's start off with teriflunomide. Teriflunomide inhibits pyrimidine synthesis, preventing those activated cells and lymphocytes from proliferating and dividing. And it's been used in multiple sclerosis in clinical trial. In addition, this is a metabolite of leflunomide, which has been used for rheumatoid arthritis with 2 million patient year experience. Teriflunomide is a dihydroorotate dehydrogenase inhibitor, and it's a once daily agent. The clinical trials were 2 trials. One was TEMSO and one was TOWER. And both of these looked at a 14 milligram dose and a 7 milligram dose. And what we saw in the trials is both doses were effective, but the 14 milligram dose had significant effect on disability in both trials. In the TOWER trial, we saw a reduction in relapse rate of 36%, and it also slowed down the progression of disability by 31.5%. In the TEMSO trial against placebo, the 14 milligram dose also reduced new relapses by 31% and slowed down the progression of disability by 30%. In addition, the TEMSO trial had MRI data, and it looked at, for example, enhancing lesions. And enhancing lesions were reduced 80% by being on teriflunomide 14 milligrams compared to being on placebo. One of the concerns with teriflunomide is it does have potential side effects like all medications. One of those is liver enzyme elevations, diarrhea, and there can be transient hair thinning or alopecia after initiation of treatment. Like many of our agents that are coming and medications available, we do not recommend patients getting pregnant on this agent. Another agent available for the treatment of relapsing MS, hopefully in the near future, will be BG12. And BG12 is an agent that affects both neuroprotective and anti-inflammatory pathways through what we think is NRF2 pathway. And this agent, dimethyl fumarate, is an exciting new potential compound for the treatment of MS in the near future. The medication involves 240 milligrams was one of the doses that was looked at in clinical trial development. And in the DEFINE trial, 240 milligrams twice a day significantly reduced the proportion of patients having relapses over the course of 2 years by 49% versus placebo. BG12 twice a day also reduced the annualized relapse rate by 53% and also reduced the progression of disability by 38%. So very positive outcomes, clinical outcomes in the DEFINE trial. In addition, we saw changes on MRI, like reduction in T2 hyperintense lesions by 85%, and enhancing lesions dropped by 90% by being on this treatment with BG12. Another trial that was set up was a confirmed trial, which also looked at BG12, but in this study there was an active comparator arm with glatiramer acetate. The reduction in relapse in this trial was 44% against placebo. And in addition, the glatiramer acetate had a 29% reduction in relapses compared to placebo. However, in this trial, the proportion of patients that had progression of disability was not significant in either group. Some side effects of BG12 include gastrointestinal symptoms such as nausea, vomiting, and diarrhea or abdominal pain. And most of these symptoms tend to happen early on in treatment. In addition, flushing is quite common with BG12 early on in treatment, and that may be able to be mitigated with aspirin daily. In addition, liver enzyme elevations can occur, and reduction in white count is a possibility with BG12. Now let's move on to laquinimod. Laquinimod is another oral agent in development for multiple sclerosis. There was 2 trials with laquinimod. One was the Allegro trial, which was a comparison to placebo. And in that trial, there was a reduction of annualized relapse rate by 23% compared to placebo. Interestingly, the progression of disability was also robust with a 36% reduction in the progression of disability. In the BRAVO trial, which was another similar trial with an active comparator arm to interferon intramuscular, demonstrated an annualized relapse rate of 21%. And then it also had a significant benefit on progression of disability at 33%. These results were based on an adjustment that was done with a predefined sensitivity analysis. In addition, one of the things that was kind of interesting about in the Bravo and Olego trial was a significant impact on brain atrophy. So there was a reduction in brain volume. The brain volume was dropped further in placebo than it did on treatment. The effects on T2 and enhancing lesions were less robust than we're seeing with some of the other oral agents on the other hand. There was a pooled analysis that was done looking at the two trials in terms of safety. And the common adverse events that were seen with laquinimod included headache, back pain, arthralgias, some elevation in liver enzymes, and urinary tract infections. The highest adverse event that was seen in the clinical trials for this agent were appendicitis. And then finally, let's move on to the monoclonal antibody alemtuzumab. Alemtuzumab is a humanized monoclonal antibody that targets CD52, which is on the surface of lymphocytes. So it causes a depletion of circulating lymphocytes, and that effect can be up to a year. The infusion is generally over 5 days the first year and 3 days the second year. And there was 2 phase 3 clinical trials that studied this. One was CARAMS-1 that was in treatment-naive patients. And then we had the CARAMS-2, which was the treatment-experienced patients, patients that had previously been treated with disease-modifying medications. And in the CARAMS-1, there was a reduction of new relapses compared to being on interferon 44 micrograms subcutaneously 3 times a week by 55%. So there was a robust effect on relapses. However, on disability, there was no significant impact on disability in that clinical trial, with very low amount of progression of disability in both groups. In the CARAMS-2 trial, which was the patients that had previously been exposed to agents, the annualized relapse rate reduction was 49%, and there was a significant impact on disability. The actual reduction in disability progression was 42% by being on alemtuzumab as opposed to being on interferon treatment. In terms of safety with alemtuzumab, the big signals that we're seeing are thyroid adverse events, ITP, and potentially serious infections. So that wraps up the new treatments in development. I'd like to pass it back to Ed.
Well, thank you, Barry. When we're hearing all the data on these clinical trials of the emerging therapies, I guess one of the things that we have to keep in mind is the difficulty in comparing trial to trial. We hear numbers that sound different, but if they're done in different trials, we can't necessarily just assume that one is different than the other. Also comparing it to the older trials. This is a problem that we've had as well. The trials that were done more than a decade ago really had different entry criteria and they had different outcome measures that they were looking for and definitions of relapses and so on. And so I think all of us can agree that there is an issue with trying to compare across trials that really limit our ability to say that there is a superiority. If there is a trial where they do compare to an active comparator, then it's valid. But if it's just against placebo, we really shouldn't compare one trial to another.
Absolutely.
All right, so what we're going to do right now is to discuss the key takeaways that we've had from this session and then go into the case discussion. The immunopathology of MS is complex, and it may not be the same from one patient to the other. There are different cell types that are involved in the immune system, and for one individual person, it may be one cell type that's really related to the pathology more than another. The diagnostic criteria are based on MRI, spinal taps, things that we've had as tools for us for a number of years. The hope is that in the future we'll have other tools as well to monitor patients. The newer MS medicines do seem to have, by the basis of having different mechanisms of action, they have different potentials for controlling the disease. And that one of the things that's going to be very important for us is to try and identify those patients who are not doing well enough on the current therapies in order to discuss when it would be appropriate to change medicines and what would be the appropriate strategy for that medication change. So we'll start by describing a 32-year-old woman who presents with optic neuritis in the right eye, and the MRI of the brain shows 8 T2 lesions, 2 of which enhance with gadolinium. So as we have discussed with the Magnum's criteria, it would be appropriate with the new 2010 criteria for determining that the patient has relapsing remitting MS to initiate an MS medication. In this case, an MS medication is instituted promptly. However, within 12 months, there's been difficulty with tolerability of this medication, the adherence drops, and because of that, this medicine is stopped. Over the next 2 years, there are 2 more relapses. This new medication has therefore not fully controlled the disease. And there is residual neurologic deficits with this second relapse, again, a bad prognostic sign. So the clinical decision point that we can go to right now is what patient characteristic would not be considered a poor prognostic sign for this particular case? Would be number 1, the annualized relapse rate, number 2, the sustained accumulation of disability, number 3, the MRI findings, number 4, the failure of one of the MS medicines to control the disease, number 5, the intolerability of one of the MS medicines, or 6, the duration of disease. So we ask you to choose one of those answers now. So the issues with this case are that there were a number of bad prognostic factors for this patient. The annualized relapse rate and the sustained accumulation of disability are obvious clinical factors which would indicate that this patient is going to be much more likely to accumulate more disability over time. The MRI findings were also indicative of an increased level of activity. The failure of the MS medicine to control the disease was certainly a bad prognostic sign, as patients who have poor response to one medication often do have more aggressive disease over time. The duration of the disease is a valuable point, I think, to make on this one, because it is an early stage of disease on this, which isn't necessarily a poor prognostic sign, because these patients, in fact, can have a very good response. The intolerability of the one MS medicine is not a prognostic sign at all, however. A patient unable to tolerate one medicine may do very, very well with another medication, not only tolerate it well, but also be able to have a very good clinical response. So answer number 5 is the one that would be indicative that you can't say is a poor prognostic sign for this case. The second question we're going to have with regards to this case is about discussing the choices of therapy at this point, now that we've had one medication that was intolerable and one medication which did not adequately control the disease. So the question is, which factor would most support the use of fingolimod over natalizumab in this patient? And the choices are, number 1, a history of diabetes, number 2, past diagnosis of uveitis, number 3, resting heart rate below 50, number 4, JCV antibodies found in the serum, and number 5, mild liver dysfunction on past MS medicine. Please pick your choice now. And in answering this question, before we go to an open discussion of this case and how we were going to approach it, is that a history of diabetes or uveitis would increase the chance of developing macular edema. The resting heart rate below 50 is one of the issues with regards to the possible transient bradycardia that could occur in fingolimod. And the mild liver dysfunction can occur, of course, with multiple medications, but certainly the incidence of hepatic dysfunction has been seen in some cases with patients who are receiving fingolimod, as well as natalizumab in a lesser number. The JCV antibodies being found in the serum, however, is a clear indication that this patient would be at higher risk if placed on natalizumab for the development of progressive multifocal leukoencephalopathy. And because of that, that would actually support the use of fingolimod over natalizumab. And so the answer to this question is 4. What I'd like to do at this point is to go over the summary of this case, because it's, although a fairly straightforward case about intolerability and an inadequate response to a medicine, there's nothing straightforward anymore about our decisions, about what medicine to choose and how to pick a medication, basing both the risks and the benefits of each individual therapy. So I'd like to get your opinions on how you approach these more difficult cases. Clyde, I'll start with you.
Sure. So, I think in this particular setting, you have a patient who is having intolerable issues related to the medication. So, I think it's really important that you have a conversation at day 1 before you actually choose the medication to outline what the therapy is going to look like, so that patients really understand what they're getting into, both from the standpoint of, injection site issues or flu-like symptoms or whatever the issues are, so that they feel comfortable doing that and they own the responsibility of that medication. I think that's really important. So, you try and monitor them over time, and after 12 months, which may be a long time for an intolerable side effect issue, I probably would want to assess that a little bit sooner. And what we try and do is assess them, after they're 3 months and see how they're doing, and if they're having struggles, try and address those struggles early, so that you can either change their therapy and not wait until they're having more disease activity clinically or radiologically. So I think that's an important piece. But then, so now you're looking at somebody and you have to decide on which medication to change. And as you had pointed out, the whole issue about picking a medication that says, I've got better data with this drug because, we had 60 some odd % reduction in relapses versus 30% reduction in this drug, you can't necessarily use that data across trials like that, even though, there's this tendency to want to do that. You have to still look at, what is the mechanism of that drug versus the drug that they were on, and make sure that you're trying to find something that might address the disease better. And knowing the mechanism of action, you might be able to choose more appropriately for a particular problem. If they have a lot of active MRI lesions, you may want something that has more of an effect on those metrics. So I think, you take all that data and you try and pull it together and you have a conversation with the patient to try and figure out what's going to work best and look at the risks and benefits for that individual patient and make a determination what to do. I think the JC virus antibody test is a useful test for us in our clinical practice these days, because it may give us the capability to stratify people who are going to be at higher or low risk to develop the PML issue.
So Barry, I want you to expand on that with any thoughts that you have, but I also want you to comment on whether you feel like we have a changing landscape on how we define treatment failure. Is the criteria used to tell a patient you're not doing well enough on this drug changing over time?
I think it definitely is. Ed, when you look at our older trials, the number of relapses that people were having annually, if someone had an exacerbation every year, we said that was pretty normal, that was pretty adequate. In our more recent trials, the large trials comparing interferon to glatiramer, we saw that only a third of people had a relapse over 2 years. So I think my threshold in it changing therapy or lack of response clinically is sooner. I think the more agents we have, as we have more agents, you're more willing to move on to another agent if you don't have that great response. In addition, I think we're seeing data coming out looking at that MRI scan when you're on treatment, and if you have like enhancing lesions or new activity on that scan, those patients are at increased risk for disability down the line. So I think we're pulling the trigger earlier to switch therapies when we think people don't have an adequate response. And like this patient, it's very important to kind of stratify our patients up to figure out who's at risk to go on to developing worsening disease, who's got mild disease. And I think that hasn't been paid attention to enough. I think there's a lot of patients that could do very well on our traditional injectable medications, have that long-term safety, and not need to take risk. And there's other patients that have a lot of activity that may benefit from some of these trials that we're seeing with great reduction in relapses. So I think that comes into play. Part of the tolerability issue, though, I think is very, very important, is just spending that time with the patients I try to do it a month after they start and sit down and really talk to them about, what issues they're having, how can we overcome them, so then we don't necessarily keep escalating the drug to higher risk medications very soon. I mean, they got a lifelong disease, the effect of these drugs on the immune system is important. So trying to figure out, work through those side effects, help people stay on treatment is very important. But if a patient's clearly not taking the medication, they're dropping off a treatment, and they stick with it for a while and then drop off a treatment because they don't tolerate it, then you're not treating, their annualized relapse rate is not being reduced at all because they're not being adherent to their therapy. So I think it's definitely a partnership between the doctor and the patient to come up with that game plan of where you're headed next.
I think that's a great segue to the part 2 of this program, which is going to be dealing specifically with communication with the patients. Because this is, the case, I think, the overall summary of this is that, we have breakthrough disease. You need communication with the patient to be able to determine that, in fact, clinical activity is occurring. The MRI gives additional information as well. The tolerability of the medications, whether they're on the medicine or might be on the medicine, is going to go a long way towards determining our treatment decisions as to whether the patient is on board with the plans and is understanding and willing to accept the potential, not just risks, but tolerability issues that can be defined with the medication. And that a discussion of these is really important from day one, before the medications have been instituted, before the choices have been made. So at this point, we want to go over the post-assessment questions. You've already answered these in the pre-assessment, but we're going to repeat them now. In the first question, teriflunomide 14 milligrams versus 7 milligram dose in the TIMSO and TARA trials each showed the following except, and the exception to this rule was number 4, the significant difference in safety and tolerability profile between the two doses. They were similar in both trials for the two doses. Post-assessment question 2. Which of these is true regarding the DEFINE trial? The answer to post-assessment question number 2 is 2. BG12 significantly reduced the proportion of patients who relapsed by 49% at 2 years compared with placebo. So this concludes our first segment of this activity. Thank you for joining me today. I appreciate your input on this, and I appreciate you tuning in to this activity.